been to Liberia, and during the 6 months there was a cholera outbreak and yellow fever. I've been to South Sudan, I've been to Afghanistan, I've been to Ethiopia, Liberia and Sierra Leone. A health promoter is someone who becomes aware of the culture and the traditional beliefs of a community so that they can assess which is a risky behaviour that may need encouragement for behaviour change from the behaviour that is healthy and safe for families. In case of like Ebola disease outbreak, we would visit communities or see relatives when they came into centres and explain what the disease, how the disease works, what effect it has, what the signs and symptoms are, and how we can prevent the disease spreading within the community. In other missions, we work alongside outbreaks of measles or cholera. We also go into the community when there are malnutrition and teach nutrition. We do water and hygiene. Sometimes it's quite simple, just giving information and just explaining, where their traditional beliefs differ from what's dangerous practice to what's healthy practice. It's recognising and understanding the cultural needs of the people and encouraging them through information and education to change, and that's very, very difficult. No, you don't. You can come from an anthropological background. However, I was a nurse midwife with MSF before I let my qualifications lapse. And so anyone who wants to become a health promoter, who has a nursing or medical background, who've let their skills lapse, can come as a health promoter. And it's very useful because, you're working in a medical setting, and providing you can absorb the culture and understand the need to recognise the culture, then that's absolutely fine. They're very rare in MSF, a typical day. However, for the health promoter, unless there's a sudden measles outbreak or a cholera outbreak, or someone has discovered that there's a crisis in one of the communities where you're needed, then you would do your planned work, which would be going into villages, highlighting what the medical team considered the main priority. You may do a survey. You would certainly sit with groups of all ages and sexes and discover how the people felt about the situation, areas where they would be prepared to change, areas where they were quite resistant to change, any stigmatisation that might be attached to the problem, and you would work things out in either role play, visual aids. We even in Ebola wrote an Ebola song to try and find different methods. But the idea is to find an approach which is acceptable to the communities to get the message across. I think the worst thing is when you come up against a brick wall and you just can't break through anyone's resistance to change. A lot of times it can result in the death of a family, as in Ebola, as in cholera. And the most frustrating thing is trying to find a way in and identify with the person's feelings and just trying to get them gradually to come on your side, to accept and to believe what you're saying. The best thing is when somebody, it's just like a light going on and saying, oh yes, now we see it. And all of a sudden there's a unity in thinking and, oh, now I know what you mean. Yes, well, okay, fine, we can do that. And that is the safe practice that you've tried to get across probably for days or weeks. And that moment is just, yes. Absolutely. The difference with MSF is that you get the support. You get the support before you go out. You're very well briefed. You've got the support of the team when you get there, and you're very well supported when you come back. You're constantly learning. In fact, sometimes I think I learn more than the people, communities do that I'm working with. The work is challenging, fascinating, interesting, and never boring.